Thank you so much today for this humbling and extraordinary honor to speak to you. I am deeply honored to be among such a great group of speakers. So I've been charged today to talk about the important needs of our research and clinical infrastructure as they relate to rare diseases. As mentioned in the introduction, I'm a full-time employee of the National MPS Society, but more importantly, I advocate for a group of 14 disorders, most of which mirror the rare disease community. The majority are genetic, the majority are pediatric, and the majority are neurodegenerative in nature. Also, the majority lead to fatality early in life in many cases. I started my work in 1998, and within a very short time, I went to my first fundraising run for the National MPS Society in the fall of 1998. I went to my first San Filippo funeral in 1999. The loss of our community members every week is present to all of us. And when we fight and advocate, it is with the knowledge that months matter in progress for these disorders. This is not something that we can idly stand by and watch as the research infrastructure of our country is eroded. It is not hyperbole to say that the National Institutes of Health have been the greatest driver of clinical and biomedical progress in the history of the world. They are a national treasure. They are directly responsible as a foundation for the entire biomedical and biopharma complex in this country. And they lead to discoveries and implementation of clinical progress for all of us Americans, but critically for the rare disease community. The discoveries that they make cannot be done elsewhere. They require that kind of disinterested approach that doesn't require a bottom line to be paid out at the end of the quarter. And that is what we need driving progress for the rare disease community. Indirect costs have been in the news lately as an area that could be potentially cut. Indirect costs are real costs. I have been an NIH-funded researcher for 15 years. I was trained both in graduate school and as a postdoc as an NIH fellow. These costs pay the costs of doing research. They pay for our compliance. They help pay for our animal care, for disposal of nuclear wastes, for disposal of biological wastes. These are real costs. They cannot be made up. They are rigorously negotiated. I've lived under the scrutiny of accountants at universities monitoring my budgets. They don't let you get out of line. These are critical. The failure for us to not keep the funds level where they should be will be catastrophic. A 25% cut across the board and across this country will have epochal impacts from which we will not recover as a biomedical industry and from which the rare disease community will not recover. There is going to be the loss of programs, of institutions. There will be faculty retiring. There will be faculty not taking jobs. There will be graduate students not being recruited. This is absolutely critical. It must be protected. And these timelines are both near-term and long-term. Short-term, we have programs in the pipeline being reviewed by FDA. We have newborn screening diseases whose applications are under consideration or have been approved, and states are relying on support from federal funds to help us institute and implement those programs. And these are programs that will identify patients that can be identified by no other means, and for which we have life-saving therapies. This is critical. NIH budgets that are being reviewed are critical to allowing clinical trials to proceed. In the midterm, 5 to 10 years, we have progress that needs to be made. We have new faculty that need to be trained. We have new graduate students that need to be recruited to keep things moving along. And in the long term, the discoveries made by the NIH which can only be made by these kinds of grants, will fuel the future. The truth is, all of the research progress in my diseases was made basically by discoveries from 65 to 95, and we've just been implementing those. And there is more to discover. The medical genetics community is finding a new condition every week, and those conditions will need basic, discovery-based research, hypothesis-driven research to make progress. And this can only come from the NIH. And these resources serve us, they serve the broader community, they serve our nation, and they are local supports. Local biotech industries are critical in all of your states, and they support very local economies. When I was an NIH researcher, my staff built new homes. They started families. They contributed to local economies. For every dollar that goes to the local economy from an NIH grant, there will be $5 in economic activity supported by that. But the real reason to support these is the benefits that will accrue to the rare disease community, which, as you know, is not a small community. We are large, we are important, and think of these points and others and share your stories as you go forward today and visit with your representatives and senators. Thank you very much for the time to speak.